Top Med Talk.
Hi, it's Monty Mythen here. Welcome back to EdPom 2020, live from the Top Med Talk studios here in London. So without any further ado, I'm going to dive straight in and introduce our US anchor for Top Med Talk, Desiree Chappell, who's going to be leading on this session.
Well, Monty, I'm glad you're all comfy there in your chair in our Top Med Talk studios. I'm based in Louisville, Kentucky. I wish I were in London, green with jealousy. But it really is my pleasure to introduce this very special Medtronic session on the Prodigy study. Prodigy is the prediction of opioid-induced respiratory depression monitored by capnography. And here to tell us a little bit more about the study and take a deeper dive is Ashish Khanna, who's joining us from my neck of the woods in the U.S. He's in Winston-Salem, North Carolina. He's an intensivist, anesthesiologist, and associate professor there at Wake Forest University School of Medicine. Ashish, thank you so much for taking the time out in this early morning, even though for anesthesiology it's not that early, to join us.
Good to see you.
Good.
Hi, Monty. How are you?
Good. Thanks for joining.
Tell us just a little bit more about yourself and what you do there at Wake Forest.
Sure. Yeah. So, associate professor of anesthesiology. I'm also section head for research for our division on critical care medicine. My initial training was at Cleveland Clinic, where I trained in anesthesia and did a fellowship in critical care. There, I got very interested in perioperative outcomes research. I had the honor of working with Daniel Sessler, who was my initial mentor. In fact, Leif Saager, who's part of our panel, was also one of my initial mentors. And, I dived very quickly into the world of perioperative outcomes research as soon as I was a junior faculty and got very interested in trying to understand why patients are doing badly on the general care floor. As an intensivist, it affected me a lot. You probably heard it in my talk. Those middle of the night admissions started bothering me. And I was very interested in the rapid response call side of things. And with a lot of big data analytics, we were able to do a lot of, neat projects over there. And then after spending about 3.5 years at Cleveland Clinic, I moved to Wake Forest here, and we're doing a lot more in terms of continuous monitoring and improving detection of patient harm on the general care floor over here.
Thank you, Ashish. But I would like to introduce our other panelist. It's my pleasure to introduce Frank Overdyk, who is professor of anesthesiology in Charleston, South Carolina. Frank, thank you so much for joining us. It's wonderful to see your face again. We did a great podcast that went out in the Top Med Talk zone this morning.
Frank.
How are you doing?
I'm great. Pleasure to be here. So my academic interest has been opioid pharmacokinetics and its impact on ventilation. And about 20 years ago, I came across my first case of opioid-induced respiratory depression, which was a tragic death in a young woman after surgery. And since then, I and others dedicated to patient safety have found that this is not an isolated problem. We have about 150,000 cardiopulmonary arrests on the ward in the U.S. per year, a place where we send low acuity patients that we expect to find alive and well in the morning on rounds. We know that a significant number of these dead in beds are related to opioids and sedatives, which makes the mortality completely preventable with better respiratory monitoring. So 15 years ago, we did our first study on continuous oximetry and capnography at St. Joe's Candler in Savannah, Georgia. And we found ORID, opioid-induced respiratory depression, to be quite prevalent. And you saw some of the data in Dr. Khanna's presentation. What is remarkable is that our results are almost identical to those we found in the Prodigy study 16 years later, done in 7 countries on 3 continents. So our in-hospital opioid crisis, as I call it, is still here. It's been here, and it'll not go away unless we do surveillance monitoring on our ward patients. And that's my passion and interest.
Yeah, we can tell it. That's whenever you say dead in bed and some of those big key terms, I mean, we have all heard of that, and it definitely does impact us all. Now, Frank, Monty.
Frank, just to be clear, this phenomenon is happening in some of the well-resourced hospitals in the world. Is that right, Frank?
It is.
This is not a community hospital problem. This happens in the famous hospitals that we've all heard of in the United States of America.
Correct.
Thank you for clarifying that. That's scary, isn't it?
Yeah, absolutely. Again, the resource piece. Frank, you were going to comment on that?
Yeah, and it's based on really Monty, on a fairly antiquated monitoring triage that we have on the wards, which is this intermittent 4-hour monitoring. And you can imagine our patients have gotten sicker. In the old days, we had lower acuity patients in the hospital, but now we put fairly sick patients on a ward, and we have to just monitoring them, spot monitoring every 4 hours is not sufficient. A continuous monitoring is what everybody really deserves.
I'd like to introduce our next panelist, Leif Saager from Germany. He is the Executive Vice Chair of the Department of Anesthesiology in Germany at the University of Nottingham. Now, Leif, I know that you've had some experience with the MPOG, or Multi-Center Perioperative Outcomes Group out of Michigan. Can you tell us a little bit more about that?
Last year, I moved back to Germany to take on this new position. But before that, I was at the University of Michigan in Ann Arbor for about 4 years and had the opportunity to work there at the Multi-Center Perioperative Outcomes Group. That's a very unique and interesting collaboration of about 50 hospitals across the US that decided to share their perioperative patient record. And basically, it was started by Dr. Chappell, way close to 10 years ago. And he built this electronic perioperative database with a very collaborative and academic spirit. And over the years, there are now way more than 12 million patient records, very comprehensive in this data set. So there's an opportunity to do real world research and look at practice pattern, what actually happens. It's whenever prospective randomized trials as the gold standard are very important to create the evidence. But every time you do a prospective randomized trial, you've got inclusion criteria, you've got exclusion criteria, you narrow down your study population to get, a very specific result. But once you want to generalize your result and open it up and broaden it, it becomes tricky. So these kind of data sets that are comprehensive and representative, are very helpful.
Gotcha. Well, we'll come back to that in just a bit because I know that you've done some work that we want to discuss. But Ashish, I'd like to turn it over to you and just tell us a little bit more about Prodigy, just very, very quickly, the study and the primary outcomes of the things that it was looking at.
Sure. So Prodigy was really born about 4.5 years ago. We had published some initial data where, obviously Frank had published his work 15 years ago, and then we had followed it up with some neat experiments while I was at Cleveland Clinic, where we had looked at, what I showed in my slides, that, patients were hypoxemic all the time on the general care floor. We weren't picking up this hypoxemia. There was no easy way to predict for this hypoxemia. And really, we were starting to think, well, what should we do? Should we put all our patients in continuous monitoring? Are we then converting our floor into an intensive care unit? There'll be alarms all over the place. No one's going to respond to those. Or should we actually have some sort of a real-time scoring system that's developed from continuous waveform data? And that's how the idea of Prodigy was born. Prodigy was also based on the fact that we're missing ventilatory events. So as I said in my talk, hypoxemia is just part of the piece. And honestly speaking, especially when you talk about opioid-induced respiratory depression, hypoxemia apparently is not the complete answer. So we're missing the ventilatory side of things. So we decided to do Prodigy, and we said, okay, we wanted to be representative of a global patient population. So we said not just hospitals in the US, hospitals in Europe and Asia as well. As we all know, the issue with opioids as postoperative analgesia is slightly different in North America versus Europe versus Asia. For example, in Asia, people, get away with not using opioids for good reason. And a lot of them are opioid naive. So we wanted this to come together as a global effort, generalizable to a global population, and that's why Prodigy came to be.
Great, thanks. Tell us about your work with capnography. I know you've alluded to it, but tell us a little bit more.
I don't have a poster of oximetry behind me. I have one of capnography, and I can tell you why. If I had to pick one continuous monitor on the ward, I would pick a pulse ox because it gives us oxygen saturation, gives us heart rate, pulsatile flow, the pleth, So it gives us both respiratory and hemodynamic. But supplemental oxygen is so pervasive on our wards these days, and everybody on this call understands the oxygen dissociation curves. You could hypoventilate significantly, and the pulse oximeter will only be a very late warning. And on a ward setting, that's a much more difficult thing to monitor than in an OR. So basically, the pulse ox alone is too late. And we have shown that capnography can be used, which is used in the OR, obviously, and has made procedural sedation so much safer, can be used on the ward successfully with the proper training. And there's several centers that I know of, one in Savannah, Barnes Jewish in St. Louis, that actually prefer the capnograph. But you got to train the folks right in them. It's not all about the end-tidal CO2 number, because remember, with a nasal cannula monitors CO2, you're not getting a full end-tidal breath, as opposed to with an endotracheal tube. So, but the patterns we see of breathing that doctors recognize, that nurses on the ward who are properly trained recognize, they can spot a sleep apneic a mile away where the pulse ox maybe would not do. So there's tremendous value in capnography in that setting.
Such a great point. And I think we're going to be able to get to some of that too on the Slido questions. Quickly, Leif, tell us about the work that you've done with MPOG, and you were telling me the opioid induced respiratory depression events and things like that after surgery.
Yeah, so MPOG is a perioperative data set, right? And we have those opioid-induced events on the floor, but of course the analgesic regime on the floor is heavily influenced by what we do in the operating room, right? Regional anesthesia, long-acting anesthetics, blocks, all those things, they influence the analgesic requirements of the patient post-operatively. And while we tend to think that we practice similarly, that is not true at all, right? There are so many local flavors, individual practices, experiences to it, that even if you have places that have strong SOPs in place, there's broad variation. And one of those opportunities in those large data sets is that you actually look at what happens. What do people actually give to the patient? And then if you go on and say, we've got 50 hospitals across the US, from the big academic centers to community hospitals, and you look at individual surgeries and say, well, look at primary hip replacements, look at primary knee replacements, look at colectomies, at specific cases, and see how practice varies in those cases. You can do historical views and go a couple of years back. MPOC started, as I said, 10 years ago. So you can go back a couple of years, see how the practice changed. You can identify patterns locally, but you can also identify patterns for, specific patient populations. But it's not all retrospective, right? If you want to get the comprehensive pain management picture, a lot of data that you're interested in is not necessarily automatically collected in an electronic record. Oh. So we together with the University of Utah and 11 other hospitals, we came up with the concept of enhanced observational studies, right? Prospective randomized trials are expensive. They take a long time to perform, and you're very focused in your answers. So what we suggested, and we could interest 11 hospitals to participate in this, is redirect departmental resources for just a 2-week period of time. And within those 2 weeks, those 11 hospitals did a comprehensive assessment of patients pre-operatively, and they made a post-operative pain assessment, and they called them 30 days afterwards. And within 2 weeks, 11 hospitals, we got a little over 1,000 patients prospectively, where we collected very, very detailed opioid therapy naive data, pain scores, very comprehensive assessments. We did the same assessments follow-up, and it was the departmental resources that went into it, but it was very different from, doing an NIH trial on a large financial burden on this. So we're very grateful to those hospitals who participate, but it was very doable to do this. And you learned interesting patterns, and you could see how from the hospitals that utilize, for example, we converted those into morphine equivalents, we adjusted for length of surgery, all those types. But you could see, if you compare the lowest opioid utilizing hospital to the highest one, it's a factor of 4 easily, that the amount of opioids differ for the same, adjusted for the length of surgery, same type of surgery, other variables. And you see it's an incredible increase. It's a very different way how we practice it. And so post-operative analgesic regime, obviously is heavily influenced by what you do perioperatively. So yes, we need to monitor those patients, but I do think we also need to better understand how we provide analgesia for those patients. And I think there is room to optimize as well.
Absolutely. Well, Monty, any comments? And then if not, should we go on to Slido?
I think the main thing we should do is go to slide. Yeah, we have 37 questions. And I think realistically at the moment there are 1, 2, 3, 4 that are scored over 10 votes from people. So I think we should crack on with those as a priority. Shall I pull the first one out for you?
Yep.
How much do you think partial stroke inadequate NMB, i.e. neuromuscular blockade reversal, contributes to post-pulmonary complications, perhaps in combination with opioids?
Well, Leif, do you want to take that one?
Shall I bundle that one in the second one, if I may? Because why as a group, because I think they overlap, and the answer may overlap as well. Why as a group would we prefer to save money by avoiding sugammadex to reverse rocuronium to ensure complete reversal? Lack of reversal more than an issue, I think. So I'm going to bundle those two in the interest of time.
I'd be happy to take it, because we just looked at our data set, at the MPOC data set at postoperative pulmonary complications, comparing sugammadex versus neostigmine. And, pulmonary complications, we look at about 45,000 patients, and postoperative pulmonary complications occurred in about 4% of those patients. And you could clearly demonstrate a difference. You had a reduction of about 30% if you would reverse patients with sugammadex versus neostigmine. So clearly, that residual neuromuscular blockade plays an important role in pulmonary complications and respiratory depression post-operatively. I would argue that you got to look a little bit at the time frame, right? Prodigy looked way out, 24 hours, 48 hours post-operatively. At that time frame, you don't talk about residual neuromuscular block anymore. That's a topic for the more immediate post-operative period. There, it does play an important role as well. But as you move on to the regular floor, I think that part becomes less and less, and the analgesic, the opioid portion grows bigger and bigger. And, after 24, 48 hours, that's the issue. It's not neuromuscular block anymore.
Yeah. Ashish, comments?
Yes. So slightly, I think I was going to say I have a slightly different take from Leif, but he finally got us back on track. I think Prodigy, or not just Prodigy, if I look at the whole issue with surveillance monitoring on the floor, or understanding why our patients are deteriorating on the floor, I think it's beyond just neuromuscular blockade. I think neuromuscular blockade is certainly a key component. I'm not, discounting neuromuscular blockade, but from what Leif said, I'd like to reemphasize that a lot of events occur 24 to 36 hours after the patient has come out of the operating room. And that's certainly a time where residual anesthesia or neuromuscular blockade has nothing to do with what's happening. The other thing is that these are postoperative pulmonary complications that we're talking about, versus where what we looked at is just waveform data. That those are monitored, detected respiratory depression episodes, not necessarily a pulmonary complication. What we're trying to say is that if I am going into repetitive cycles of desaturation and hypoventilation, I do believe that if the drama starts at 12 o'clock midnight, then there will be a problem that's going to happen about 4 a.m. in the morning. And we need to intervene early to prevent that problem. Now, that's not a pneumonia. That could just be a sudden respiratory arrest. And that is slightly different than the problem of a atelectasis or a pneumonia that's secondary to patient not taking deep breaths or having residual neuromuscular blockade. The other part about sugammadex that like all of you or neostigmine think about is when these drugs first came out, when sugammadex first came out, it was mostly used in the complicated reversal of neuromuscular blockades. So there was a difference in the reintubation rate. If institutions across the world look at reintubation rates comparing neostigmine and sugammadex and look at it in 2014, when we first started using sugammadex, it was being used for the more complex patients. Now it's used, fortunately or unfortunately, is more common. So reintubation rates are not very different at all. Neostigmine versus sugammadex back 4 years ago might have been very different.
Yeah. Frank, did you want to comment on that?
If you monitor everybody, you can handle all these complications in proper time. So I agree with what they both said, but with monitoring, the problem is solved.
Good point. Well, so Monty, let's go back to Slido. A couple more questions.
So if you did a pre-op sleep study on these patients, would you not find similar frequencies of desaturation? Aren't you just monitoring sleep?
Well, certainly we know, we've always suspected that patients with obstructive sleep apnea have deep desaturations. And we actually looked at that in patients preoperatively and then looked at them postoperatively. And we noticed that those deep desaturations became deeper and longer postoperatively. So the combination of opioids superimposed on sleep disordered breathing is a very dangerous combination. Sleep apneics don't typically die at home in their beds. They have arousals in which they can rescue themselves. Those arousals are blunted by opioids and sedatives, so that puts them at risk postoperatively. So it's a good question. Yes, those folks, you can see it preoperatively. I'm not sure it's going to make things a whole lot better. The risk is still there.
We're going to go
quick. Of course, you'll know about those patients.
Sorry,
Yeah.
Desiree. I suggest
Monty.
we go quick fire on these unless another panelist disagrees. If you share them out as I serve them up, if someone disagrees, they can fire themselves in. Is that okay, Desiree?
Yeah, perfect.
Great stuff. Is Tiva better than sevoflurane for conscious level and respiratory function in post-operative period? We've stopped using desflurane due to environmental concerns. That is from Nicola, Scotland.
All right.
I don't know
Ashish,
if that's
I'll go
Nicola
with you
from
first.
Scotland or somebody called Nicola Scotland. But Nicola, thank you very much.
Ashish, we'll start with you and we'll walk down the line here.
Sure. I don't know of the data on that, but I would say that yes, there are situations where desflurane versus sevoflurane might be better. Again, personal experiences, we've moved away from desflurane for various reasons. Have not really seen a great benefit using des versus sevo. And again, similarly, Tiva only when specifically indicated. I will say that it does not make a difference in overall, outcomes on the floor. Again, yes, it might make a difference in length of stay in the PACU and so on and so forth. But is that clinically significant? Maybe not.
All right. Frank, your opinion, quick.
It's a matter of how long the infusion is with Tiva, whether the effects last to the floor. So I agree with Ashish. In the PACU, it would be the only place it makes a difference, not on the ward.
Right. And Leif, comments.
We were more heavy on the Tiva administration, but I do agree as well. I think it's only the PACU. I don't see any big clinical differences between sevoflurane or the Tiva on the regular floor.
Okay. We are going to be wrapping up here quickly, but I do want to let you know that Ashish will be in the discussion room at the Medtronic table. So you can be sure to join in there where you'll be able to ask questions. Monty, couple last Slido questions for us.
What about spinal opioids with regards to postoperative respiratory depression?
Frank, did you guys look at that in Prodigy?
So no, we did not. Spinal opioids are a different issue. They do cause opioid respiratory depression. If they mean for laboring patients, it's sort of a different scenario. So typically on the ward, nobody is getting spinal opioids. It may be a residual from the OR. But there is always that risk, and it depends on obviously the lipid solubility and what you're using. But again, if you're monitoring patients, you can detect those issues.
And Ashish.
Yeah, I guess the point I want to make is that Prodigy, if you look at patients who did or did not have respiratory depression episodes, there wasn't a huge difference in the morphine equivalents of opioids that they received, which is interesting because you would assume that it's all happening because of opioids. I think it's multifactorial, and that's what we've picked up. The waveform data is definitely convincing, which there is specific pattern changes that happen where we can say that it's opioid-induced respiratory depression, where Prodigy was interesting because, folks like, Leif Saager were involved in it, where we sent all the blinded waveform data to him, and he, with other experts, looked at it and said, this is artifact, this is opioid-induced respiratory depression, this is non-opioid-induced respiratory depression. Opioids are a factor, but you cannot discount other reasons for respiratory depression. In the end, it's multifactorial, and that's exactly what the Prodigy risk score has shown as well.
And Monty, we want to take one more question?
Well, I'm going to bundle these two together then. Very quick comment on which sedatives are being given with opioids on the wards and why. And I think, to me, one of the most pertinent questions, it refers back to an earlier session in which Dr. Swart talked about the idea of 1.5 care. And it says, should all wards have the capability for continuous monitoring? I think this is probably one of our dirty little secrets in medicine, that we're not necessarily honest with people, that they come into hospital and they can be very sick and they get monitored every 4 hours. Why in this day and age do we not have continuous monitoring for everybody?
All right, Ashish, we'll start with you.
You see, my hand went up like even before the question finished. Right?
I think everybody was nodding on that one, though. Ashish, go ahead and start. We'll take.
Yes, that's right. I want to take that second part, and because I'm very, very passionate about that part. Why all wards should or should not have continuous monitoring, and I can say that from personal experience. Here at the university hospital I work in now, we've had continuous patient monitoring on the floor, portable continuous monitoring for the last 4 years. And I will tell you that based on the 40,000 patients that we have till now monitored, it's interesting. The whole issue is not just putting a patient on a monitor and walking away. The whole issue is the efferent arm, the intervention arm. We have spent, and I'm part of the task force here that looks at all the alarm data that comes back and says, when are providers actually intervening based on those alarms? And we have had to adjust our thresholds all the time and adjust the delay on the alarms and the escalation and the alarm tone and volume to make sure that there is appropriate intervention. I can tell you that we're still struggling with like blood pressure alarms. We don't know what to do with low blood pressure because patients are sitting and talking like I'm talking to you with a map of 55, right? They might have myocardial injury, God knows, but no one knows what to do with them. Similarly, someone might have chronic hypoxemia. You don't know what to do with them, right? So I think continuous surveillance monitoring is really important, but it's the efferent arm, educating people on what to do and how to handle alarm fatigue is as important, if not more important, if we really want to make a difference in clinical outcomes.
Frank, I think I know your answer, but please tell us what you think.
So really, the three impediments to adoption have been alarm fatigue, workflow, and capital expenditures. All of these three have been solved to a large degree. There's still some challenges, as Ashish says. Alarm fatigue can be handled with proper training and proper setting of the alarms, and we're getting many more smart algorithms on alarming to fix that problem. Workflow, the efferent arm is what we're talking about. Traditionally, monitoring is about fixing the afferent arm, the detection part. Now we have to respond in a proper way. That has been solved by the institutions that have adopted this successfully, and there are many, many more that have done so in the last 5 years. And the last one is capital expenditure. It is up to the manufacturers and to the health systems to figure it out. But a pulse oximeter is anything you can get at your local Boots or Walgreens, whatever country you're in, and you can get it for $15. So there's no reason that that there should be a patient who does not have continuous monitoring on the ward. These problems have been solved.
Amen. All right, Leif, close it out for us.
I completely agree. I think in the final version, every patient should be monitored on the floor. I think that's what we need to target. That's what we need to go for. But we don't need to roll it out all on day one. So I think if we still see that there is problems with alarm fatigue, right? You need buy-in, you need nursing, you need caregivers to support this and buy into the monitoring piece. If you burn that early on by constantly sending out just annoyance alarms, you're not going to get very far. So I think as we roll it out, targeting high-risk population, because they need it first. Those are the high-risk patients. And then moving on, and as we get better algorithms, as we get better technology, as we get better in our workflow, we roll it out in the whole hospital. But I think the goal has to be that at the end, all patients are monitored for their safety.
Well, on that note, gentlemen, thank you so much. Oh, Frank, one more point. Quick.
Yeah, we can't wait too long. Everybody needs to start doing this today because people are dying still. Thank you.
Thank you very much. Great wrap up. Gentlemen, I can't tell you how much we really appreciate you joining us for this very special Medtronic session, which is typically lunchtime when we're all in person, but wherever you are, at whatever meal you're having. Thank you for joining us. Cheers, everyone. Thanks so much.
Bye.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.